Hi everybody, I hope you're enjoying your afternoon away from class, and I do hope you take a few minutes to watch this PowerPoint video. Today we're talking about core vocabulary intervention. It's chapter 5 in your book, and I have uploaded all the videos to Google Doc or whatever it's called. If you email me, I will invite you so that you can watch the DOD or the videos from our book via the web file. So let me go to the first slide here. So we're talking about core vocabulary intervention approach. And the background for this approach is that speech processing is very complicated. Obviously, it involves several domains. One domain is first you have to have a sensation. You have to perceive that sound is there and perceive the words that are being spoken. Then cognitively and linguistically, you have to recognize those chains of sounds, those phonological representations. And sometimes, as we talked about, certain sounds do not become salient to a child. They're not something that they pay attention to, or it could be that certain sounds are absolutely absent from somebody's ambient language. And we've used the example of some sounds that are in German or Norwegian may not be present in the English language or even Spanish. And so then you don't hear those sounds when you're young, and you have a hard time learning how to say those sounds. So there's maybe something going on in that realm for some of these children. The next thing that happens is the output. What we have to say is very complicated. So we have to make a plan. And it's pretty amazing when you think about it. I'm just sitting here verbalizing, and the ideas start in my brain, but they have to travel through the system and come out my mouth and make words that are understandable. So it's not surprising when you think of how complex this system is that some children actually have a problem and don't learn to speak the sounds that they need to. But more than that, some of these kids don't respond to the typical ways we try to treat them for speech and language therapy. So we get these cases where some children are not being understood, their frustration level is very high, and what happens in some cases is they are tantrum thrower children that become very hard to manage or have behavioral problems. And it has found with kids like this that have these type of severe issues, if you choose 70 highly powerful words and target those words, you can really reduce that frustration and increase the child's intelligibility. And in the form of you take 70 words, and we'll talk about picking those words that are chosen by the family or the child or together with you. Target about 10 words a week. You target consistency in isolation and in targeted speech. And then you also choose some non-target words that you don't work on and see if there's some generalization that's occurring. The populations that this is good for include children with clients that are from age 2 or up. They are going to have fairly inconsistent errors, and we'll talk about differential diagnosis from apraxia. We suspect that these kids, again, have some speech processing difficulties, and even though they've been getting speech therapy, these errors that they have just continue. But the errors are variable. So when somebody asks you, well, what do they do for specific sounds, you may have a problem giving a straight answer. So for example, on the slide, the word tongue could be produced as buns, dun, ba, m. So you've got different productions for one target word. Similarly, the word which could be produced as b, at, whack, or what. Zebra could be produced as jiwa, ayua, dwa. So you get many different productions of one target word. And that makes it difficult to describe, and it makes it difficult to imitate what they're doing as well. Secondary populations, you can use this method for children who are as young as 2. Also, it's been effective with preschool children up to children in school age all the way up to middle and high school that have what we call these functional speech sound disorders characterized by inconsistency. We also see it works with kids that are bilingual and those children with Down syndrome. So here's that differential diagnosis I was talking about. A little bit, as I was describing, some of you may have been thinking, well, do these kids have apraxia? The answer is no, they do not have apraxia. When we think about children with apraxia, and again, we'll have a whole session on apraxia, but we'll see that children with apraxia have inconsistent errors. We do see inconsistent errors with this subtype of inconsistent speech sound disorder. Kids with apraxia are going to have harder times with words that are longer. So beater, beating, they would break down in that word. But you'll see that with kids with apraxia and kids with inconsistent speech disorder. Here's where you're going to start seeing some diversion of the two populations. Children with apraxia will have sequencing error or metathetic errors, metathesis. Syllables will slip out of order. Tornado becomes tornado and such. You're not going to see that as much in kids with these inconsistent types. It's not that the syllables are slipping out of shape, it's more that they're just picking strange sounds to substitute into the words. A child with apraxia is going to have trouble imitating, but yet a child with a speech sound disorder is going to be better in imitation than they are in spontaneous conversation. Kids with apraxia are going to be flipped around that way. They're going to be better with spontaneous or automatics than they are with imitating. Kids with apraxia are going to have oral motor difficulties. You may see them having trouble, especially with sequenced movements. Pucker, smile, stick out your tongue so it would look like this. They couldn't sequence that. Where that type of ability would be within normal limits with these inconsistent speech sound disorder types. The hallmark of apraxia is groping. The child thinks that they're going to be making a rounded sound and they realize they're retracting, they're groping around. You're not going to see that groping or silent posturing in kids with speech sound disorders. Kids with apraxia are going to have slow rate of speech, sometimes even their melodic line or their prosodic piece is off, and their dido-cokinetic rates are going to be off. That's not going to be the case in children with speech sound disorders. So when we go to assessment, is this going to be a good method for my client? There is a nice diagnostic. It's called the DEEP, the Diagnostic Evaluation of Articulation and Phonology Test. And there's a subtest on this DEEP, D-E-A-P test, where it's called the consistency, or you're looking for inconsistency subtest. A score greater than 40% means that greater than 40% of their productions are inconsistent. And that's a hallmark that this type of therapy, this core vocabulary approach, might be a good approach for that child. So just a quick outline of that diagnostic subtest. In that DEEP, it's 25 naming pictures. So pictures like girl, dinosaur, elephant, and there's 3 trials of production. Although you separate the trials by an activity. So you would look for the production of the word girl. So the child says the word girl in the first repetition, fine. The next repetition, they might say goal. And so you would you would transcribe that, score that. They would get a score of 1 now because he didn't make it identical to the first production. And then the third production may be go, now a different rendition of girl, then that would be a score of 2. One score was consistent with the target, and then 2 were not. So you look at that, you get a total number of discrepancy scores. If you have a discrepancy score of 40% or more of the productions, that does indicate that you've got a consistency problem with this child. So for these kiddos, it's really hard for you as a clinician to describe what their errors are and to analyze the error pattern, because they're just so hard to get a handle on. They're so variable with their speech production. Also, it's so as I was saying, it's hard to describe and analyze the errors, but really it's even more difficult to decide what target to contrast the sound with. So you wouldn't know which sound to contrast with the error because it's a moving target for these kids. And so that inconsistency is the tricky piece, and the substitutions are variable. And so the typical protocols we use for these children aren't quite as effective. So the theory behind this method is we know that all children are going to have their own little idiosyncratic phonology when they first start to produce words, especially for those first 50 words. Kids will have their own way of saying bottle, baba, Maya, and such, Maya for mama, or blanky bei. They have their own production of their first 50 words. After the first 50 words, then we start seeing patterns to the errors in your typically developing children. So these signals of these error patterns is showing that the whole system is starting to reorganize from a whole word chunk to the segmental phonological system. We usually see this reorganization happening by the second birthday. And by age 3, that inconsistency in production is reduced to about 13% and about 14% by age 4. Children with this continued inconsistency often are the kids that are unintelligible. They're good candidates for this vocabulary method. So when these kids have these inconsistent errors, not characteristic of apraxia, we suspect they have processing issues, maybe lexical vocabulary deficits, decreased linguistic knowledge altogether, and then we see these output processing errors. So thus the intervention is going to target that impairment in speech processing. And we're going to do this not by stimulating listening, we're going to have them consistently produce phonological plans for words. So you as a clinician are going to establish a consistent, even if it's not the exact target, but a consistent production of the words. You're not going to target the surface errors that we would do in a contrast therapy. Instead, you're going to make that consistent production of a set of very highly powerful or highly useful words for that child and develop a phonological plan for each of those words. The best consequence of this is that intelligibility will be impacted. We have some nice levels of evidence for this procedure. If you remember our level of evidence, the quality of the evidence gets better when you have systematic reviews. There are meta-analyses of using this method that are prove it's a good method. We have randomized control all the way to the bottom level of correlational and case studies. A typical session is going to last 2 times a week, 30 minutes a session. You're going to take 10 words of your 70 words, and you're going to drill those sounds to elicit the best production of the word. And you're going to give them that practice homework, and I'm going to run out of time.